before starting talking about the management of hemodynamics coagulopathy, we might have to touch upon certain factors about indications and the phases of liver transplant to start off with. So as you all know that pediatric liver transplant has been performed by Thomas Starzl in Pittsburgh in 1967. So since then, the outcomes of the pediatric liver transplant was somewhat better compared to the adult transplants, even though the last 2 decades, the pediatric liver transplant has become a state of operation with excellent success and limited mortality. So we can find out why is the reason is we can have a lot of improvements in terms of anesthetic monitoring and pediatric intensive care, and also the organ availability in terms of split liver grafts and living related donors, which provided a lot of organ support, and also the improvements in the immunosuppression, which all lead to improvement in the graft and patient survival, leading to up to 95 or even more in some centers. We have 98% success rate in pediatric liver transplant. And our centers is our pediatric liver transplant survival for 1 year survival is more than 95%, and for 5 year survival is again 90 to 93%. So why is it different? Is it different from adult and pediatric liver transplant? Yes, there is definitely a unique challenges and the difference between the adult and pediatric liver transplant. It's just because of the even within the 12-year age group, we have a lot of differences in the etiology in terms of neonate, infants and children. Particular characteristics have different etiology and different comorbidities present in this population. So because of this, the surgical techniques also is challenging. Yeah. So is there a designated liver transplant team is necessary? Yes. So there is a study in the University of Wisconsin. They've identified, they've looked into the details of the parameters, and then they found out that the liver transplant anesthesia team compared to the, they talk about the etiology. I mean, it's the red ones are the common in neonates, and the violet ones is infants, and the black one is common in older children. So if you see this chronic liver disease, most commonest what we found is the biliary atresia, and some of them are in the viral hepatitis. You can see autoimmune hepatitis. It's not common, but you still see some older children. You can get to see this kind of diseases. And in Middle East and some of the Indian population, we can have metabolic disorders in terms of Wilson's disease and galactosemia and Craigie-Littler syndrome we see in certain patients. So acute liver failure, rat oil poisoning, drug-induced and viral hepatitis, you can see as well. See, why is it very important? So each metabolic liver disease or ALF have got a different etiology and different clinical manifestations, which might need intraoperative CRRT or preoperative also. These patients needs to be optimized using a CRRT, and then they come for operation. So in case of biliary atresia, these children may have a failed Kasai. We can have intraoperatively, we might have challenges in managing this patient. So indications for transplant is very important. As a anesthetist involved in this care of patients, we should be involved in the pre-transplant meeting. What are the challenges you can expect based on the etiology, and then you can optimize and manage during the intraoperative and postoperative period. So based on our data, so RMC we have done, this is from January 2023, it's 550 transplants we have done, and after that we have done another 50, so around 600 transplants we have completed in RIMC alone. So biliary atresia around 46%, metabolic liver disease around 24%, and PFIC around 11%, and tumor around 5%. So around 85% of the population of the pediatric category is these 4 diseases comprises of this 4 etiology. Apart from that, another 15% you have autoimmune hepatitis and acute liver failure and cryptogenic and vascular malformations. This can happen in another 15% of the patients. So commonest is you have either metabolic or biliary atresia in your day-to-day practice. So what challenges do you have in cardiovascular issues is you will have a increase in cardiac output and low systemic vascular resistance. Congenital cardiac anomalies is common. It's because in this age group you can have any type of congenital cardiac abnormalities you can see. Either you can have a ASD, simple problems like ASD, VSD, or it can be a combination of syndrome with tetralogy of Fallot as well. Pulmonary hypertension, portopulmonary hypertension, and cirrhotic cardiomyopathy is rare. So it's not seen much in the pediatric population. So if the child has got some pediatric congenital cardiac problems, so we need a multidisciplinary team approach. So basically, the interventional cardiologist and the hepatologist and the surgeon and anesthetist will be involved in the pre-transplant meeting and decide about whether this particular problem, whether we can manage intraoperatively and postoperatively without doing anything for that intraoperative, cardiac anomaly. Sometimes we might have to do a cardiac procedure by taking care of these patients can decompensate while doing the procedure and then having a transplant post-procedure as well. So we had one such situation that pulmonary stenosis severe enough, then transpulmonary gradient more than 25. So we did the balloon valvuloplasty, and then 2 days later we did the transplant. But luckily the patient didn't have any decompensation. The child didn't have a decompensation. So always the close communication between these multidisciplinary teams is very important, because it's very common to have pulmonary stenosis in patients with Alagille syndrome, which is one of the commonest indications you can have in your in your liver transplant practice, pediatric liver transplant etiology. So why the cardiac output is high is because of the portopulmonary fluid retention and portal hypertension, and then the low SVR is due to reduced clearance of vasoactive compounds like nitric oxide. And ASD and situs inversus is common in extrahepatic biliary atresia children. I've already told you about Alagille syndrome, which is characterized by bile duct toxicity and cholestasis and cardiac defects. It could be ranging from VSD, ASD to tetralogy of Fallot. So we need to have a clear-cut investigation modality like a cardiac catheterization to find out if this patient can be done without uncorrected anomaly. Cardiomyopathy is rare. It can happen in retransplant patients where they have immunosuppressive medications with tacrolimus. And cardiomyopathy criteria is left ventricular mass index is more than 95 grams per meter square, and relative wall thickness of left ventricle is more than 0.42 millimeters. If this is a mild form of cardiomyopathy, where this can be identified using the echo and cardiac catheterization. If it is more than 109 grams per meter square, this could be moderate risk. This might be a contraindication for liver transplant. So we need to evaluate before going in for transplant. So otherwise, most of the times we might end up having problems intraoperatively, which might not be correctable, or we might lose the child as well. Portopulmonary hypertension is very rare. Any suspicion should arise if there is a risk, new heart murmur, syncope, or dyspnea. Echocardiography can show this right side of the heart is similar or even bigger than the left side of the heart. So we might have to do a right heart catheterization to find out if it is higher than more than 35 or moderate or severe, then it might be a contraindication for operation. The most important part of our program or the liver transplant, pediatric liver transplant, is preoperative evaluation. Because one, it's a size of the child, and two, it could be metabolic indications. Three, it could be comorbidities like either pulmonary or cardiac manifestations. So meticulous preoperative preparation to focus on etiology is important. So in case of Alagille syndrome, we have a congenital heart disease. Hyperoxaluria needs a special mention. It's because the child can have hypertension, renal failure, and heart failure because of the oxalate crystals. Oxalate crystals can have on the heart as well. So leading to ejection fraction, low ejection fraction, and contractility is low. So this child may be on dialysis. We might have to increase the dialysis from 3 times bi-weekly dialysis to 5 times a week dialysis to see whether this cardiac contractility is improving, the ejection fraction is improved from 35% to 68% by then. Then only this child can be operated on. This should be optimized before going for surgery. Most often, this child might need a combined liver kidney transplant. But again, if it is child is very small, it's less than 10 kilos, they go for sequential. Only the liver alone they might do, and then followed by once the child is big enough, they can have a kidney transplant later. So till that time, the child may be on CRRT to avoid this kind of a oxide crystal on the load on the bone and the liver and the kidney as well. Alpha-1 antitrypsin deficiency and cystic fibrosis exhibit pulmonary disease, and hemochromatosis again cardiomyopathy and anemia. So all these things needs to be evaluated well in advance before this child coming for a surgery. So then only this optimization, this management of the hemodynamics and even coagulopathy. Most often in this patient, metabolic liver disease, the synthetic functions are normal, and so you might not have problems with that. But post reperfusion, this child may have end up in coagulopathy. So we need to look into all the details of that. And special situations I've already mentioned, the metabolic disease. Some of the metabolic disease we need to avoid albumin, and so we have a metabolic consultant which gives guidelines. The child should be on sodium benzoate, carnitine, even on the day of surgery to avoid metabolic crisis and maintain the blood sugars, and maybe the use of bicarbonate to avoid the acidosis. These are the things we need to. Some children, we routinely put them on dialysis to avoid metabolic crisis and even in acute liver failure child. And monosegment and auxiliary, this picture shows the uphold where with the native liver in acute liver failure, where there is a regenerative nodules are present. You use that as a native liver, be part of the native liver will be there, and then recipient the donor liver, half of the donor liver will be there. Subsequently, in years time or up to 2 years time, then the native liver can avoid giving the immunosuppression, leading the native liver to regenerate completely to stop the immunosuppression. So this can be a tricky for us as an anesthetist inside the theater, because there is a lot of cut surface, there's a lot of hemodynamic instability. Management of hemodynamic instability is very important. Regarding monitoring, I think most of the major surgeries, the standard monitoring and the invasive monitoring is same. ECG, pulse oximetry, end-tidal carbon dioxide, temperature and NABP, and ventilator and depth of anesthesia monitoring is all our patients needs to have. And invasive monitoring in terms of arterial and central line. And if you see, this child needs to be draped completely to avoid hypothermia, and lines and tube needs to be secured. And you can see at least a foot away from your head end. So it will be difficult for you to adjust anything once the surgery is started. So you have to be very meticulous in preparing the child before operation, the shoulder roll below the shoulder, and then there is a sandbag to lift the abdomen. All these things needs to be sorted before starting of surgery. And neuromonitoring in case of ALF and arterial ammonia, pupils, and ONSD and TCD, we do have a continuous ONSD and TCD monitoring for an adult patients. Pediatric patients, we do see only the pupils and the ammonia. Cardiac output monitoring, we don't use routinely cardiac output monitoring in children, but we have used TEE probes, smaller TEE probes in one or two cases who had an interventional procedure preoperatively. So otherwise, the role of cardiac output monitoring in our experience is limited. Flow track is though extensively used in adults, not validated in children. And you have a TEE probe, smaller probes are available. Only issue is you need a significant skill, and it carries a risk of esophageal varicose bleed. So the child needs to be, whether the child is having a severe portal hypertension, having a bleeding, those kind of children might have to avoid. Otherwise, most of the children you can use TEE if you are significant enough, and if you have a skill you can have. You can still use a DE probe, which gives you a good, excellent assessment of ventricular filling and function. Pulmonary artery catheterization, maybe cardiac anesthetists who have pediatric cardiac anesthetists who might be very good in doing this pulmonary artery catheterization. Definitely it gives you a good dynamic cardiac output monitoring. But we don't routinely use AMN in adults because we have a PICO monitoring that we do use for an adult in an adult setting. Pediatric, there is a study it shows that in pediatric population, even PICO monitoring is useful, and it helps to make critical decisions about hemodynamic stability during pediatric transplant. So, I mean, during the slideshow, you can have a little bit of it monitors SVV and the extra lung water index. If it is more than 7, it means that the GRWR is high and you need more volume for that. So, and blood products use might be there. And you have a Getty and the cardiac index, if it is low, it also shows you that the GRWR is high, and then you might need more blood transfusion. So PICO monitoring in children is validated, and still it gives you a good amount of good cardiac assessment, volume assessment in terms of how much blood volume you need to give and how much blood volume, I mean, blood and blood products you can give, not blood and blood products, how much volume we can give through this, based on this PICO monitoring. Is it going fast? Or are you okay with the speed?
This is fine.
This is fine.
So before starting of this operation, so 2 big peripheral lines, upper limb peripheral lines, upper extremity peripheral lines is important. If you don't have one, try to put 2 central lines can be useful. So the femoral lines might not be useful for children. The reason being, unlike in adult patients, you have a piggyback technique, whereas here the complete KV clamp is almost inevitable in most of the pediatric transplants. So upper extremity lines is more important. If you don't have one, try to put 2 central lines. I mean, we used to put 2 central lines on one side, but ideally you can try with both sides, one on each side you can do. And regarding the arterial line, when we started our program, we used to do 2 arterial lines, one in the femoral and one in the radial. But it's very convenient when you have a hemodynamic instability, you can use one for monitoring, one for taking out bloods. But last 5-7 years or 7 to 8 years, we stopped doing that. In case if you needed some blood transfusion, blood products taken, we take it from the central line. In case of difficulty, we take it from central line. So we use arterial line as a monitoring. So we use 1 central line, 1 arterial line, 2 big peripheral lines is the norm for any pediatric transplant. And these catheters, we have a lot of different sizes of catheters. If it is less than 10, we use 4.5 French and 6 centimeter triple lumen catheters. Or if it is between less than 10 to 15 kilos, we use 4.5 French and 8 centimeter triple lumen catheters. And more than 15 kilos, we use 5 French and 8 centimeter triple lumen catheters. So this should be standardized. Otherwise, it will be difficult for you. So what are the lines you need to have in the pediatric liver transplant? And again, for the vascular access, in case of metabolic liver disease or in case of acute liver failure, you have 3 sizes of vascular selection. So these needs to be put beforehand for going for an operation. So you have 3 different sizes and 2 different lengths. We can use it for based on the weight of the children. Arterial line, if generally we use radial arterial line, it's 40 millimeter ones, 40 millimeter length. And for the femoral line, you will have a 3 French 60 millimeter ones. Very rarely we use femoral lines for our pediatric children population. Only the PICO line for an adult we use femoral line. Otherwise, generally right or left radial we use for most of our residents. So again, this is very important to have anesthetic induction drugs, emergency drugs, infusions. We have a lot of online calculators, and even Queensland, Melbourne have got an online calculator. You can calculate through that and keep your infusions ready beforehand, before starting of management of pediatric transplant. So to start for the intraoperative management, so most of you, I think you might all have been involved in liver transplant. Then you might know the phases of liver transplant. But if not, you'll have three critical phases in management of liver transplant. One is the dissection phase, where the skin incision to removal of the native liver, and then anapatic phase, from the removal of the native liver to reperfusion, where the hepatic and the portal vein anastomosis is done and the reperfusion is done. The neohepatic phase is after the reperfusion, the hepatic artery anastomosis and bile duct anastomosis and abdominal closure. These are the three important phases of liver transplant. But each phase has got a different management or different situations and happen. So we need to know what are the challenges in your dissection phase and anapatic phase and neohepatic phase. I'm going to talk about now the dissection. Before that, I'll tell you about what are the investigations you do during the liver transplant. So most often what we do generally in our unit is every hour we do a full set of labs, ABG, and then we use a ROTEM. ROTEM is our normal point of care testings. If you have a thromboelastomogram, you can use that as well. So ROTEM, ABG, and full set labs, which includes CBC, INR, and fibrinogen. It can be done even before also if you're going to give more blood and blood products, or if you need for blood products, you can do it even half an hour or 45 minutes after the transfusion. So this gives you a clue about how to manage your patient during the phases of your liver transplant. So dissection phase. So which patients, based on the preoperative evaluation and the etiology, you can identify which patient can have a difficult operation. So massive blood loss in terms of you can expect in failed Kasai operation or any other intra-abdominal operations, and cocoon abdomen with repeated SPPs, cholangitis, and growth retardation, and high PEL scores and severe portal hypertension. These are some of the cases or pediatric children can have a lot of hemodynamic changes, and the challenges are monitoring or how to assess the blood loss during these phases, because even a small 5x5 or 10x10 gauze can hold up to 35-50 ml of blood for a wet soaked gauze. So it will be like 10 to 15% of the blood volume in a 5 to 7 kilo child. So you need to be very careful in assessing, because you might not have a section, you won't get much on the section, or much you won't see. That's why this constant communication with the surgeon is very, very important, or it's paramount importance in doing a liver transplant in pediatric population. This again, the pre-existing coagulopathy can worsen this bleeding, and then the retraction of blades, the Thompson retractor can impair the diaphragmatic movement, can lead to hypoxia, and then even it can impair your twisting of the liver, can cause this hemodynamic instability. All these things we need to be careful and identifying all these parameters even in advance. And then as an anesthetist, you need to be having constant communication with the surgeon to relieve the tilting of this liver. Some situations where you can allow them to little bit of preloading of blood fluid and blood products will be useful. So your goals are to maintain the hemodynamic stability. If the blood loss is more than 10%, try to give a blood and blood products for this hemodynamic stability. Or if it is less than 10%, you can use 5% albumin or crystalloid solution, and judicial use of vasopressors can be used. And acidosis, electrolyte balance, and normoglycemia, normothermia. This again, it's a critical situation where you might you might have to do maybe half an hour once to look for the sugar levels in these children. So they might be on dextrose infusion for metabolic diseases, where this can cause problems with the metabolic crisis. So we need to continuous infusion of 25% or 50% dextrose in these children, and monitoring them to keep a blood sugar level around 150 in most of these children is very important. Avoid acidosis and electrolyte imbalance, and it's again It's very important in acute liver failure and metabolic liver disease. So sodium bicarbonate infusion might be needed to avoid this acidosis. And electrolyte imbalance, generally they are okay. The children are okay with levels of potassium or calcium with a little bit on the lower side. So, but to make sure that the potassium levels should not go beyond 4, or that's our critical limit. You can keep it before the reperfusion. So guidelines for transfusion varies between institutions and anesthesiologists. So our target the threshold would be between 7 and 8 grams per deciliter during the dissection phase. Close communication is very much important, because most of the times their inputs, it's very useful, and monitoring, because sometimes they tell that, okay, there is a blood loss, like 20-30 ml of blood loss in these children. So you might have to catch up, or you might be okay with a little bit of vasopressor to monitor that, maintain that hemodynamics instability. For coagulopathy, so you have point of care testing is very important. So it should be guided by either ROTEM or TEG, and standard laboratory tests like INR, fibrinogen, and platelet count, as well as surveillance of the surgical field, where you need this input from the surgeons. And transfusion trigger for PRCs should be set as low as 7 grams. I can tell you why it needs to be kept as low is because of the vascular complications which can happen later on. And later on in my part of my lecture, I'm going to talk about why it is important to keep your hemoglobin levels around 8 or maximum 7 to 8 during this operation. And calcium, again, it can cause, if it is low, it can lead to myocardial depression and further hampering of coagulopathy. So keep your calcium levels at the normal, try to keep it at normal levels. So in CLD patients, this is very important. You call it either rebalanced hemostasis or precarious hemostasis. They call it precarious hemostasis. This one end, you have a bleeding tendency. Is because of the low platelets and platelet dysfunction, and you have a low procoagulant factors and low fibrinogen and low antiplasmin. So these all this can cause your bleeding tendency. Whereas the other side, you have a thrombotic tendency like high von Willebrand factor, and you have a low Adams 13, that is low von Willebrand factor inhibitor, and also in high factor 8 and low anticoagulant proteins and low plasminogen. So you have a balance between your low bleeding tendency and a thrombotic tendency. This is not challenged in a normal situation. That's why most of the chronic liver disease patients might not bleed without, if you're not doing anything. When they are decompensated by means of infection, or if the patient is going to having a surgical insult, this balance has been changed, and it can lead to bleeding, or sometimes it might lead to even thrombotic tendency also. So that's why your point of care testing like a thrombo TEG or ROTEM is very, very important. This slide shows the upper part is a TEG analysis, and ROTEM. Both are same. I mean, you can use one is the, both are rotatory cups. One is rotating, the needle is rotating in ROTEM, and the cup is rotating in the TEG. But it gives you this similar sort of information, and so you can use either ROTEM or TEG. If you see this clot initiation time, is either R time, it's a reaction time in a TEG, and CT is a clotting time in a ROTEM. So this is up to amplitude up to 2 millimeters. And the K are kinetics time, and CFT is the clot formation time in ROTEM. It gives you from time in minutes from clot amplitude to increase from 2 to 20 millimeters. So this gives you a clot formation time. So if you are going for an MA, it's maximum amplitude, and MCF, it's a maximum clot firmness. It's ROTEM. In lysis is clot lysis and lysine index in ROTEM. So these are parameters you can see in, you can identify when you are sending in a ROTEM or TEG, you will find all these parameters in the ROTEM. But for you as an anesthetist in an intensive, in a theater setting, you might need to look for only 2 parameters. One, so if you are taking a ROTEM, you're looking at the how fast is the CT time. It's delayed. If CT is prolonged, it indicates that the clot formation is delayed. So in that case, you might have to give a fresh frozen plasma. But if the clotting time is normal, then you look for the strength of the clot. That is MCF, maximum clot formation. That is, if you look at that, and if it is low, then it can be due to either fibrinogen or platelet. So you look at the septum. If septum MCF, if the maximum MCF is low, give cryoprecipitate, and if septum MCF is normal, look for the extem. That is the if already the platelets is low, so you can give platelets. So if both are normal, if lysis is present, tranexamic acid. This slide, it gives you for an adult population, but generally for a pediatric patients, we don't use tranexamic acid because it might be contraindicated, and I will talk about it later. Intake is similar kind of a R time is prolonged, give FFP. If MA is maximum amplitude is weak, if it is low, either you look for the fibrinogen fraction and plate mapping. Depends on that, you can correct with either fresh frozen plasma, cryoprecipitate or platelets. So I'm going to show you three slides. One is in the left, you have a hypocoagulable rotum. So your CT is prolonged and CFT is prolonged, and then your MCF is 31. That is also low, and your septum MCF is 8. It's low. So based on this, if I ask you, what you will do if you have this kind of a rotum? So based on the rotum, you can give INR correction for CT CFT because it's delayed, and then your extem MCF is low, it might need platelet, and your septum MCF is low, you might need fibrinogen. But having said that, you might have to see discussion, and you can see the field and discuss with the surgeon whether is it the coagulopathy bleed or is it a surgical bleed. If there is no coagulopathy bleed, you can keep it as an hypocoagulable rotum. Needs correction, when in need you can do the correction. Otherwise you can wait not to do anything about it. But if it's a coagulopathy correction, you can start giving some INR correction like FFP, and then wait for the cryo and then platelets till you get better with the INR correction. Sometimes you end up giving even with hypocoagulable rotum, you might have to give some heparin also. So this patient, you might be get away with only giving FFP correction. So if in the right side of the slide, you can have a hypercoagulable rotum where the CT, CFT is prolonged, your MCF in septum and your MCF in the extem is also prolonged. What it tells you is this is an hypercoagulable, and you can even tell your surgeon that this is an hypercoagulable rotum. So if you need some anticoagulation, like in the form of heparin, what we normally do in our setting is the heparin. So you can tell after the arterial reconstruction, we can tell them that the heparin can be given. So bolus dose of some heparin can be given during the surgery itself. Many times, even with hypocoagulable rotum, we might end up giving some heparin and intraoperatively for the complex arterial anatomy. Fibrinolysis, this is an adult rotum where you have a fishtail appearance where you might have to give it tranexamic acid, but in a pediatric situation, pediatric population, we don't give tranexamic acid as such. We might, if I need to correct with I might correct with cryoprecipitate. So during the anapatic phase is the next. So dissection phase is most probably your problems are maximum with bleeding and how you managing your massive blood transfusion, assessment of your bleeding and coagulation correction. These are the important factors in your dissection phase. Whereas in anapatic phase, liver is out, no clotting factors are formed, and your fibrinogen is deficient, hypocalcemia, all can lead to the hemorrhage. And also because of the reduced gluconeogenesis and increasing lactate, you have a worsening acidosis as well. So electrolyte, metabolic abnormalities, and also coagulopathy, and also hypothermia. All these parameters can happen during this anapatic phase. So you might be aware of this trauma triad of death, where you have a coagulopathy, acidosis, and hypothermia. The vicious cycle, one leads to other. It can lead to disseminated intravascular coagulation, and even death. So we have only maybe this anapatic phase is usually it will be around less than an hour. So once they start implanting, the warm estimate time around 50 minutes to 1 hour. So this is the time you have to catch up with your coagulation parameters and then metabolic and electrolyte imbalance within that short span of time. So the reason for hemodynamic stability during this period is cable clamping. It can even lead up to 50% decrease in preload. The one thing important consideration you might have to look for is the child with acute liver failure, metabolic liver disease, and tumor, where there is no collaterals. So if they might be having a significant response, hemodynamic instability can happen with this patient because there is no portal hypertension, no collateral formation. So they won't tolerate this cable clamping for a long time. So you might have to give a little bit more fluids for this kind of children before before putting the clamp on. So this communication needs to be with the surgical team, because some of the surgeons will do trial clamping and see whether the child is tolerating, and then whether they will allow us to fill them a little bit before they do the complete clamping. Because once cable clamp is done, it will take 50 minutes, at least 40 to 50 minutes to an hour to complete the anastomosis. Your goals are during the anapatic phase is adequate intravascular volume. So if you give more volume, I mean, once the reperfusion is done, the integrity, the infusions, whatever you give, can have a graft congestion. So to avoid that, use of vasopressor is very important. So judicious use of vasopressor to increase the vasopressor to support your volume transfusion. So normal CVP, maintenance of normal CVP, it's not an indicator like an absolute value is not useful. It's a trend of a CVP is useful. So for that, you need to have if the child starting CVP is around 8, so we might have to keep that CVP around 8 for that matter. Target hemoglobin can be 8 grams per deciliter or recommended, and support coagulation in terms of use of ROTEM and TEG. One of the most important thing in liver transplant is reperfusion. So reperfusion, which can lead to, because of the cold acidotic fluid with high potassium ions and with various ischemic factors can go into the circulation, which can cause low systemic vascular resistance, and also can have a ischemic reperfusion injury, which can lead to hypotension, malignant ventricular arrhythmias, and even in severe cases, cardiac arrest. So we need to be prepared for that. So how we can do that is, and also some of the vasodilatory mediators are differential. In the right side of the heart, they can have a constriction of the pulmonary arterioles. On the left side of the heart, it can have a systemic vascular resistance, reduced systemic vascular resistance. That's why you have a right-sided pressures go up post-reperfusion, leading to cardiac arrest and graft congestion and graft failure. And patient body temperature also can drop during the reperfusion. And post-reperfusion, you can have hyperkalemia, hypotension, and cytokine load leads to pulmonary hypertension and right ventricular failure, and even systemic vascular decrease in systemic vascular resistance leading to cardiovascular collapse. And in terms of coagulation disorder, you can have a hypothermia, acidosis, and hypocalcemia, and a lot of qualitative defects in the platelet function, and apparent effect and fibrinolysis can lead to coagulation disturbances. Post-reperfusion, so most often we normally go with the Agarwal et al. Definition of decrease in MAP more than 30% below the baseline, which happens within the lasting for at least 1 minute, occurring during the first 5 minutes after reperfusion. But it does not tell you the late effects of the reperfusion by Agarwal et al. So that's why it has been modified by Helmy et al. It's been mild and severe or significant. Mild is if it doesn't, the MAP and the heart rate doesn't touch the baseline or 30% of the baseline, and not lasting for less than 5 minutes. And it usually responds to calcium or simple measures like epinephrine or calcium without need for start of vasopressors. This is the most commonest form of reperfusion you can see in living donors in a situation. If it is a deceased donor transplant, you might be having more problems because of the graft size and the donor-derived risk factors like a macrostatosis, fatty liver, and then cold ischemia time more than 10 hours. And these are parameters which can cause, we can have a severe reperfusion, significant reperfusion syndrome. And also some of the factors, these are all the factors you can't do much about it because the donor-derived factors, we don't have much control. Whereas some of the things which we have under control is the recipient factors. We have hemoglobin, keep a hemoglobin around 8, and the CEP around 5 to 8 grams, and the acidosis is being corrected. Electrolyte imbalances, if there is hypocalcemia and acidosis, if it is there, you can correct it. Magnesium levels, you can correct it. And even some of the recipient factors like high creatinine and comorbid conditions, high MELD scores, and discrepancy with the graft size. Some children will have a big graft, and those times you may not be able to do much about preventing this reperfusion syndrome. Whatever in our control, like hemoglobin, keeping up the hemoglobin, and up to 8, and acidosis, correcting acidosis, these are the parameters you can do to avoid post-reperfusion syndrome. And Fakasova et al. And he is the defined the reperfusion into 3 phases. Phase 1 and phase 2 is similar to Agarwal et al. And Helmi et al., where this 5-minute portal vein reperfusion to 5 minutes after portal vein reperfusion. That is 5 minutes after the reperfusion, where you can have an abrupt hypotension, which is observed, which can be managed with vasopressors and volume loading. And phase 2 is after portal vein reperfusion to portal hepatic artery reperfusion. This might take another 30 minutes. And so during this time, you can have a systemic vascular resistance low, and decline in MAP can happen during this time. And phase 3 is from hepatic artery reperfusion to 240 minutes after portal vein reperfusion. What he tells us is, if the phase 1, if you have an abrupt hypertension lasting for more than 5 minutes, you will have more problems during the phase 2 and phase 3. So it gives you, most of the times you can see that if it's a prolonged period of hypertension or recurrent period of hypertension requiring inotropes, these patients can be having a prolonged period even up to hepatic artery reperfusion, and then slowly getting settled over the period of time. All these parameters, vasodilating metabolites, interleukin-1, tumor necrosis factor alpha, and all these metabolites is getting metabolized and getting better over the period of time during transplant. Measures. So again, so careful filling, avoid overfilling, and meticulous use of vasopressors and inotropes. And this is the time you can have help with the cardiac output monitoring. If you are having only the arterial and central line, you might not be able to assess the cardiac output. So TE or PICO monitoring will give you an indication whether the cardiac index is low, so we can use some inotropes, or if its SVR is low, we can increase the vasopressor and a little bit of filling to maintain the hemodynamic stability during the reperfusion. Actively can correct the hyperkalemia during acidosis during reperfusion. So all measures needs to be taken. If the potassium is more than 4.5, get the potassium below 4, and around 3.5 to 4.5. I mean, that is the range you might have to keep it before reperfusion. And when you are doing pediatric transplant, everybody should be familiar with the PALS, pediatric advanced life support, because the chances of getting a cardiac arrest or cardiac defibrillation is very rare. But if it happens, it could be catastrophic if we don't know what are the doses and how to do about it. For the PALS guidelines needs to be followed. And for simple, in our unit, Dr. Ella used to do, I mean, they used to do a very slow reperfusion over up to 5 minutes, 2 to 5 minutes in case of hemodynamic instability. In children, I mean, in adults, normally we don't see much of usually the tachyarrhythmias and hypotension is the commonest reperfusion and hemodynamic stability you will see. Very rarely in children, you might have a bradycardia, and once we had like 2 or 3 times went up to 30, and we have to give some adrenaline, even though the blood pressures are quite normal. I mean, up to 150, even in a small kid. I mean, bradycardia and hypertension is common in children. Not common. I mean, it's not uncommon to have during the AV perfusion phase. So beware of this. And in this situation, whatever the inotropes or vasopressor might not work, adrenaline might work in this situation. So neohepatic, it's considered as this is the time of stability. If the organ starts functioning well, this is period will be a stability where you have a stabilization of acid-base status, electrolyte abnormalities, and even the graft starts to produce bile. So it shows you like a stability period where you can catch up with your coagulation, and you can fluids and titration of your inotropes. All this thing can happen during this Roux-en-Y neohepatic phase. So this is the time where they do the Roux-en-Y anastomosis and hepatic arterial anastomosis, Roux-en-Y anastomosis. And coagulopathy can persist during this time. Again, use of rotum and tech-based correction and communication with the surgeon always helps to manage this neohepatic phase. The one thing we're mentioning is if you start giving more fluids, and that can cause graft congestion and can lead to graft dysfunction later on. So maintenance of CVP, low CVP, or judicial like an adequate level of CVP around 4, not more than 5 in most cases, and with the little use of vasopressors, you can manage this situation easily. So in pediatric liver transplant or for an living liver transplant, there's 2 important complications which can even be catastrophic for graft rejection or graft failure. So in pediatrics, it's even more likelihood to have as vascular thrombosis. It's in Cochrane review, around 18% of patients can have hepatic artery thrombosis, and 10% up to 10% can have portal vein thrombosis. This is because due to protein C, protein S levels, plasminogen antithrombin levels are low, and increased levels of factor VIII. So there is tendency of thrombotic risk in spite of hypocoagulable rotum. I mean, you can see that I've showed the rotum which is hypocoagulable, where we have to give some heparin in this child because after the arterial anastomosis, they feel that because of the complex arterial anastomosis, we have to give some heparin for this child. So risk of fat, when do you expect risk of fat is greater arterial discrepancy. There is a donor and recipient arterial size discrepancy might be there, and low child patient weight, reoperation, and longer surgical time, higher blood viscosity. So again, if it's hemoglobin is more than 10 or viscosity hematocrit more than 33, then it's slightly increased risk of thrombosis in these children. So in our unit, we used to give 40 to 80 units per kilogram bolus of heparin, followed by infusion based on APDT ratio. Our data out of 550 patients, our portal vein thrombosis rate is 3.2%, and hepatic artery thrombosis is 1.6%. And it can happen. I mean, all this is commonly you can see Budd-Chiari disease and pre-surgical portal vein thrombosis, or even in case of Budd-Chiari syndrome, biliary atresia, where the portal vein is small, they might need to put a jump graft, and those are the times. I mean, this can have a portal vein thrombosis, and so we might have to give some little bit of anticoagulation intraoperatively itself. Though the INR might be 3.5, fibrinogen around 80, platelets around 35 to 40,000, and you have a hypocoagulable rotum, still we give 40 to 80 units of heparin during the intraoperative period itself. And vascular thrombosis, how to minimize? Keep hemoglobin less than 8, and use of take your rotum rather than use of standard laboratory tests such as APDT and PT for cirrhotic patients, and prophylactic use of aspirin and heparin as per institution protocol. We use heparin intraoperatively, and day 1 up to day 1 or day 2 we use heparin as per institution protocol. And once the child is extubated and taking orals, we can change it to aspirin. And recommendation against the use of PCC Antifibrinolytics, factor 7E, Nova 7, all these things should not be used in children because the risk of thrombosis is more, and if it is going to happen, it can be catastrophic as well. To finish off, even the most children, I mean, if the child weight is less than 10 kilos or even if it is less than 7 kilos, we normally use a reduced graft or lateral reduction or even monosegment grafts. Even that is also can cause the problems in closing the abdomen. If you can't close it, and you can use a stage closer using a PTFE graft or skin-only closure to avoid tight abdominal closure can lead to hemodynamic instability, and also sometimes it's even the flow to the liver can be compromised. So we do routinely use Doppler post closure, and if we are satisfied with this, then only we'll go with that. Otherwise, we change it to PTFE closure for the abdominal wall. For blood and blood product for transfusion, you can use this formula, but there is various online calculators, so omnicalculator.com, health pediatric transfusion, there's various calculators are available, but this is the easiest one, is a desired increase in concentration of hemoglobin times weight times 3, or some centers they use 4 as a constant for the amount of PRC required. For example, if you're a 10 kilo child requiring 2 grams increase in hemoglobin, so 2 grams, 2 times 10 times 3 is 60 ml. If you give 60 ml of blood, you can increase the hemoglobin concentration to from 6 to 8 kind of. So this is a rough calculation where you can use it for your use. And again, FFP is 15 ml per kilogram, and cryo and STP is 5 to 10 ml. So to what we generally do is up to 15 kilos, we reserve 50 ml bags. So thereby, even though we can use more, so for example, if you have a 10 kilo child, you can use up to 15 kilos, means 150 ml of FFP you can use as for full correction. Whereas we have only 50 ml bags. So we will give 150 ml bag and repeat the rotum and see whether it is okay, with acceptable limit with communication with the surgical team, and we are okay with that. Then we won't give more. So the correction might be around 30% or maximum up to 50% correction. Most of the times it's okay, because the balance might be, as I showed you in my previous slide, the precarious balances or rebalanced hemostasis will be there. So cryo and STP, again 5 to 10 ml. So you can give 5 ml per kilogram to prevent thrombosis. So again 50 ml bag for a less than 15 kilos children, and more than 15 to 30 kilos, we use 100 ml bags. So thereby prevent patient blood management system helps to avoid giving more blood and blood products without indication, and 2, it's avoid even wasting of blood and blood products in case of it's more convenient and safe to use this kind of bags for children. So you can check with your blood transfusion medicine whether they can give smaller bags which can help with your transfusion as well. And this again, whatever I told in the previous slides, I'm just put it in the one slide. During the dissection phase, you expect blood loss and fluid and blood products resuscitation. And during anapatic, your IVC is clamped, so your volume resuscitation, and with the help of some inotropes or vasopressors, and maintenance of coagulation abnormalities, and metabolic and electrolyte abnormalities you have to correct during this procedure, and removal of the diseased liver and reperfusion. So plan for your reperfusion, prepare well, adequately anticipate and prepare before the reperfusion there, because you will not have time, because only 40-50 minutes of time for the warm ischemia time during reperfusion. So correcting quite a lot of electrolyte imbalance or acidosis might be difficult, and reperfusion, correction of metabolic abnormalities, and neohepatic, your hematocrit should be maintained less than 25%, and fluid management needs to be monitored. So there is a possibility of extubating the children if everything goes well, short surgical time, stable hemodynamics, not much blood transfusion. These children can be extubated, at least not in OR. They can be extubated in 2 to 3 hours time, even in ICU. That can be done. So that is the whole idea of the pediatric anesthesiologists who involved in this care of children liver transplant. They managed to do it within 2-3 hours of operation post liver transplant. Having said that, our routine practice is the children goes back to ICU, ventilated. The next day morning we do Doppler and all our parameters. We look into all the parameters, and we started then extubate, plan for extubation by early morning by 8, 9, 10 o'clock, like that. Having we started implementing fast tracking for adult patients, unless you have a criteria checklist. If they follow, if they fulfill all the criteria, we extubate in 2 to 4 hours time after going to intensive care. Early postoperative phase, maintain hemodynamic stability in graft function and hematocrit level less than 25%, and regular use of rotum based coagulopathy correction. And so, having said, people try to thinking of over correcting and infusion and fluid overfilling. All this can cause graft function, leading to judicial use sometimes can cause perioperative hypovolemia, can lead to organ dysfunction by regular work. So focus ultrasound, like using an ultrasound volume assessment in terms of lung, in terms of heart, we can see, and then based on that we can assess the fluid status, and we can replace fluids as well. To conclude, so pediatric liver transplant is a super specialty, but it's profound understanding of the physiological and metabolic changes in end-stage liver disease helps in maintaining the quality of liver transplant anesthesia at this point of time. And remarkable changes happen during each and every part of the surgical step, like anahepatic dissection and post-hepatic neohepatic phase. You need to be aware of all these things, and constant communication and expertise, structural conversation with the surgeon helps to overcome all these problems. So thereby you can have a team approach in dealing with the pediatric liver transplant. To conclude, I mean, I can show you, this is one of the, this is Dr. Ayla has got a 5-day-old child. It's a Guinness record. So did a transplant in 1998, and now she is around 25. She's 25 years old and a practicing lawyer. So this is the reward of doing a pediatric liver transplant. The children are so nice and nice to grow and watch and lead a very normal life. So compared to the adults, the pediatric liver transplant is always rewarding, and you can see these children before and after. I should have put one poster about the child who had a transplant, and 2 years later how they are like a flourishing, blooming children together. So pediatric liver transplant anesthesia is an important subspecialty where you can make changes to and with the help of the surgical team, you can do wonders. And this is again the pediatric liver transplant is one which is done in India in 1998. Now he is a practicing doctor. So it's good that I have given me an opportunity to talk about this topic. I'm quite happy to take questions.
What crystalloid do you use regularly during liver transplant?
What do you use regularly for liver transplant?
Crystalloid.
Oh, okay. What crystalloid we use regularly in pediatric liver transplant? See, generally our protocol or whatever we use in our center is Hemacel. That's a colloid, and then first of all we use 5% albumin, and then half NS. This two is the colloid is a 5% albumin, and crystalloid is half NS. To certain stage, if the sodium is low, then we use a 0.9% NaCl, and if the sodium is normal, we can use Kebelite till after post reperfusion. So either use Kebelite 0.9% NaCl or half normal saline as a crystalloid, and colloid use 5% albumin in certain situations. For example, if it's a metabolic liver disease where you need to avoid albumin as protein, you need to avoid crisis. So in those situations, we use Hemacel in case of pediatric transplant. So otherwise, 5% albumin and crystalloid 0.5% off normal saline or Kebelite.
Thank you, Robert.
Ratan, this is Rohan. Hi, can you hear?
Yeah, yes.
Yeah, just a couple of questions. The first
Please.
question is, we have been using portocable shunts regularly during the explantation. So, and what we have noticed is sometimes, especially after taking the portal vein in the hepatic artery, and if the dissection takes bit too long, we find that the patient gets big vasodilated. Is it because, I don't know how to explain, is it because of the relative ischemia of the liver, or what's your experience with that?
And the thing is, we do portocable shunt. I mean, you might be aware that we don't do that many portocable shunts in our children.
Yes.
Only in difficult cases to avoid if you expect more blood loss, or if it is going to be a difficult surgery, they do portocable shunts. And sometimes, I mean, Dr. Rajesh prefers to do a portocable shunts preemptively itself. And in that way, it helps actually. It reduces blood loss. And two, it even helps in congestion, less congestion of the bowel and things. So it is definitely, it helps as an anesthetist. We might be little bit cautious while doing the portocable shunt, while waiting for the portocable shunt. Once portocable shunt is established, in fact, we have more stable compared to when the child doesn't have a portocable shunt. So our experience is better rather than having more problems. What can happen is that because of the while doing the portocable shunt, or if the child might be sick enough, they might be having a translocation. That is a possibility. Then they might having a severe vasodilatation leading to inotropic support, and maybe requiring some fluid resuscitation during that time. That can cause problems with the bowel congestion. So what to avoid, what we tend to do is, while doing the after the hepatic artery anastomosis, we might give a little bit of elastics to aid reduce the congestion.
Thank you, Radhan. The next question is, can you describe how you set up for the portal pressure measurements? How do you set up the what specific needle that you use to puncture the portal vein, and how to calibrate the levels?
So probably I should have put a picture on that. But what we do is there is a PMO line. It's a male to male. So you can use a two three-way taps on the central line. So one, you connect it through the give it to the surgical team. And normally we don't do with the pediatrics. If it is big pediatrics, if you need a left lobe, then we'll do portocable measurements, portal measurements. But for donors, we do use portal measurements. So what this catheter goes to the surgeon, and then they use a 26 gauge needle at the end of the tubing. So what we do is we flush this line, and then we zero it, open to the air with that zero. Once we zero it, and then the surgeon will insert it into the portal vein. Then we will see the reading. If it is more than 4, I mean, usually less than 10, we would keep it for the donor surgery. If it is more than 10, we reassess the need for where to go, the MHV and all these things in bit. For the pediatric, it's not a problem because we don't measure all these things. Because it's going to be left lateral segment many times, or even mono segment or reduced segments for many times.
How comfortable are you using platelet transfusions, and what would be a trigger for transfusion?
Okay, the question is, you got it?
I thought that how comfortable you're using platelet transfusion during transplant.
Exactly, and what's the threshold? Yeah.
I mean, see, nowadays we have a lot of we use routine use of rotem in and out, not 3 times. I mean, maybe we might use more times during the part of the transplant. And so even if my platelet transfusion like NCF and the rotem is low, indicative of a platelet transfusion, even my cutoff for our institutional cutoff is up to 30,000 or 25-30,000. We are okay with surgical team. Will talk with the surgical team. Is there a bleeding and coagulopathy bleeding? And then then only we will try to act on it. Otherwise, we generally don't give platelets. We might correct with the one end of the plate INR correction and cryoprecipitate correction. We might correct platelet. We generally try to avoid correcting post reperfusion or post arterial. And even if I wanted to give, I try to give either that is, for example, if I wanted to do a PICO line and the FIPTM and the extreme FCF is low, so we might do a, if the platelet numbers are around 25,000, then we might give a one platelet correction before starting of operation. And after that, after reperfusion and arterial anastomosis is done, we'll check with the surgical team and the anastom and the rotum, then only we will do platelet correction. Otherwise, we try to avoid correcting platelet to the end. One more situation where we might give platelet or we might consider giving platelet is you end up giving a massive transfusion like 10 units of transfusion. You already removed full blood volumes like for example, if you have 30 kilo, 10 kilo child, if volume is around 800 ml, you already given 800 ml of blood. So there will be any platelet, even if it is 25,000, the platelet function might not be good. Then it is indicative with your rotum, and again your coagulopathy. In those situations, we might consider. But if you are giving 1 unit of blood and your INR is, platelet is low, we might get away without giving transfusion.
Yeah, I think Bhagya asked about this platelet count because we had a couple of children post-transplant who sustained intracranial hemorrhage with a platelet count around 20,000 like. So that was quite unfortunate where 2 children sustained intracranial hemorrhage despite correcting the other aspects of the coagulation like fibrinogen deficiency. So that is one of the reasons I think Bhagya asked about.
Post-transplant is different, Maranti.
Okay.
So I'm talking about intraoperative correction. Intraoperative correction, we can get away with it because the risk of hepatic artery thrombosis and portal vein thrombosis is slightly happening during the operation. So if it happens, you might, it is difficult to salvage at that time. So that's why we don't, I don't give. But post-operatively, if the child is having low platelet count and having a serous sanguineous drain, so you can still correct with your platelet because your artery and your portal vein is good with your Doppler. In that you can correct it because rather than but if the child is on ventilator, then you might have to correct it because you might not know when the child is having a bleed.
Is there a particular cutoff you would recommend, like 50?
No, I wouldn't go with a cutoff.
Okay.
The thing is, if you have a rotum or a point of care testing, so I would go with that because it definitely gives you a clue what are other parameters also possible. Say for example, the child might need a platelet correction. Before platelet correction, they might need INR correction and also cryoprecipitate correction. So if you correct it, the platelet, even the platelet function in the MCF and the rotum might get better. If you repeat the rotum, your MCF might be better. So you might, and again, your serous sanguineous drains can get better as well. So those situations you can avoid giving platelet. But day 2, day 3, we are okay to give platelets if it is low and if it is serous sanguineous drains, because that is more worrying. If it is even day 1 or day 0, once the patient goes back to ICU, if it is sanguineous drain, then while closing they might be okay. But after that, once they shift the patient to the ICU, if it is sanguineous drain, we might give some platelets based on the rotum. Intraoperatively, I'm talking about this because the numbers we don't need to go by numbers since we have a qualitative assessment of point of care testing available at this point of time. If you don't have, probably you can keep it around 40,000 or 50,000, depends upon your comfort zone.
Yeah, thank you.
For that, the only issue is for children, it's how much you need to give, because if you get a 200 ml bag, that might be like 4 times needed for a child of 10 kilos. So that's why we always get a 50 ml bag. It will be off correction. So it's okay to give off correction rather than giving full correction.
Okay. Thank you so much for that. My next question is, we have many children with biliary atresia and they do have hepatopulmonary syndrome. So post-operatively, the saturation target, like if I have a child who has got a pre-operative saturation of 91% in air, how should I get our post-op management guided by the saturations and the target saturations?
Okay, so this hepatopulmonary syndrome, most often, if it is mild, moderate, we don't have any problems, or even severe hepatopulmonary syndrome is PaO2 of less than 50 also, not much issues during the intraoperative period. Generally, because of the positive pressure ventilation and muscle relaxant and the flat surface, and these PO2 will be even with 50% or 60-70% of PO2, FiO2, your PO2 will be more than 100 during intraoperative period. Once the child goes back to the ICU, then only all the problem happens. I mean, or whether to extubate with the PO2 of 60, I mean, that kind of a confusion we will have. So there comes your question, like whether to accept a saturation of 91, pre-operative saturation of 91, or in our center, for a severe hepatopulmonary syndrome, we have a set of protocols. So whether we can do anything beforehand, something like CT pulmonary angio, where you can see for coiling of lesions, anything could be done. So day 1 or 2 before we do the coiling and go for surgery, because these coils, they can have a new hyperplasic vessels if you do it earlier. So 1 or 2 days before we do, I mean, not many cases. We have done few cases with PO2 of 45. We done angioembolization 2 days before coiling, before 1 or 2 days before the operation, liver transplant, and went into surgery. And then post-operatively also, we won't extubate. We extubate or sometimes we go in for tracheostomy for these children or for an adult patient. And then there is various algorithms, use of Trendelenburg position, use of inhaled nitric oxide, and use of methylene blue, and all these things we have a protocol. So use a inhaled nitric oxide, maintain saturation up to this level, and if it's not maintaining, reverse Trendelenburg, and if it's not maintaining, use of methylene blue, and all these things. And even you can consider ECMO in these children. For this children. So there is a good review paper and which shows how to manage intraoperative post-operative management of HPS patient, and we can use. I mean, we have used that protocol for any severe HPS patients.
Thank you. So sometimes we see acute kidney injury on day 1, day 2 post-operatively, where the pre-op renal functions were normal. Could you just help us tell in what could be the Sorry.
Is it for the adult or pediatric?
Sorry. I'm asking about pediatrics. Sometimes we see AKI day 1, day 2 post-operatively liver transplant in pediatric patients where their renal functions were absolutely fine pre-op. So what could be the reasons intraoperatively contributing for this AKI, and how can we minimize it?
No, I mean, the only, we don't see most often volume overload can happen. And creatinine rise in children is not common. If it happens, usually with the conservative management itself, it can get better. So volume assessment nowadays, we are not getting involved in many of the pediatric intensive care. With my adult knowledge, I'm talking about it. And again, my experience, and because I always communicate with the pediatric intensivist because they want my help during the lines and insertion and vascath insertion. So I might have some knowledge, but might not be the best in explaining how they are managing that. But what I can tell you about is intraoperatively. See, one last slide I put it like in. So if you are thinking of overfilling, overloading the fluids, end up having judicious fluid management, end up having hypodehydration, or less fluid can lead to kidney dysfunction. So this can be one of the reasons for also. So you might have to use your focus ultrasound to look for the volume status and you can use albumin or crystalloid balance to improve the kidney dysfunction. To appropriate fluid optimization might be the key. And post-operatively, they manage with sometimes with, if it is volume overload, if they see that it's a volume overload, if it's chest congestion and oxygenation is low and they have a puffy child, they might run on Lasix infusion.
Thank you.
Dialysis and peritoneal dialysis, usually they do peritoneal dialysis for a hyperoxaluria children or metabolic liver disease, they do, or acute liver failure. We put them on dialysis, CRRT, is because for the ammonia and metabolic clearance, not for the renal clearance. But generally, if the child requires kidney, if we having kidney injury, it could be a possibility of a multi-organ failure. There might not be transplantable candidate. We need to sort that out before going for surgery. Very few children we have done with raised creatinine going for surgery.
Thank you. Though I have many more questions, I'll limit this to the last question. Thank you so much for bearing with me. Sometimes, sometimes we struggle with hypotension. At the same time, we do have graft congestion. So it's difficult to use diuretics and other measures. So do you have any suggestion for us to handle that kind of a situation? Graft congestion in one side and you have hypotension requiring inotropes on the other side.
After a reperfusion, you're talking about? Or?
Sorry, I'm talking about entirely post-operative period in ICU.
Post-operative period. So you have hypotension and graft congestion because of the volume overload.
Yeah.
I mean, it is an indication for renal replacement therapy. But having said that, our pediatrician uses multiple vasopressin also. The triple inotropes also sometimes they use, and then they put them on Lasix infusion also. And you can use milrinone where or levosimendan in that situation where you can have a better control of that. If you are using a double inotropes, and then if you have a pulmonary hypertension, those causing that side of right side of the heart is more weaker. Those kind of things, if levosimendan or milrinone, you can try and use it.
Okay. Thank you so much. Thank you.
But I'm not familiar. I mean, we do use, but if you ask me how frequently do you use, means in an adult it's easy. If it's a volume overload, acidosis, lactate, high lactate, you can put them on CRRT directly. So you can monitor and then get the metabolic clearance done quickly and then get them out. For a pediatric, it's slightly different because they try to do it with more conservative measures. They use like levosimendan and milrinone, and then they use a little bit of Lasix, and they have a good resilience. Children got more. They do really well with simple measures of managing with medical management itself.
Yeah. Thank you.